wanted to look at, so MOG-IgG is measured in serum mainly at the moment. There have been a few more recent studies that have checked it in CSF. Most of these studies have been done outside of the US, so that's one reason we wanted to look at it. And we wanted to look at it in large control populations. And we also wanted to look at it because, since with the new MOGAD diagnostic criteria that just came out in 2023, that does include CSF MOG-IgG in it, but it doesn't have the same weight as a high titer positive serum MOG-IgG. So additional criteria are required. So we also wanted to see how CSF MOG-IgG would fit in with the diagnostic criteria. So what we did was we evaluated 447 CSF samples, including, so it was 4 main groups. And the first one, I'll go through each group in turn, was controls. So we had 283 controls, and that included inflammatory controls, so patients with multiple sclerosis, and non-inflammatory controls, which were mostly patients with normal pressure hydrocephalus. And out of that 283, we had 4 false positives in those controls. So that was 1.4%, that brings it to. So there was a good low number of false positives. The second group we looked at then was 74 patients that were positive for MOG-IgG in serum and had a diagnosis of MOGAD. And 89% of them were also positive in the CSF. So that's good agreement between the serum and CSF. It's similar, if not slightly higher than what previous studies have shown. And then the third group was 72 patients who were negative for MOG-IgG in the serum, but had a clinically suspicious phenotype for MOGAD, so recurrent optic neuritis mainly, or recurrent longitudinally extensive transverse myelitis. So it was to try and find cases of isolated CSF MOG positivity, so negative in the serum, but positive in the CSF, because cases of that have been reported. And out of those 72 that we tested, 9 were positive, and they all fit the diagnostic criteria, the 2023 diagnostic criteria. So it does capture those patients well, and that isolated CSF positivity can occur. And then the last group we checked was 18 patients who were positive for MOG-IgG in the serum, but they had an alternative diagnosis, so they were false positive. And we all know with serum MOG-IgG, like with any other test, we can get false positives. And especially when they're low positive, there can be diagnostic confusion with that, whether they're clinically relevant or not. So in those 18 patients, and we further divided them into low positives, and because that's when most of the diagnostic confusion is. And with the low positives, if low positive patients, if they actually had MOGAD and low positive in the serum, 80% of them were positive in the CSF. And for low positive that weren't actually MOGAD, that had an alternative diagnosis, 80% of them were negative in the CSF. So one of our conclusions from the study was that this CSF MOG can be useful if you're trying to figure out in a patient where there's diagnostic uncertainty, whether the low positive you got in serum is clinically relevant or not. And then the other thing where a situation in which it would be helpful is isolated CSF positivity. So if you have a patient who's negative for serum MOG-IgG and you have a high clinical suspicion, you could send for CSF antibodies too. Now, but the caveat with that is to make sure we're only sending it in patients that have a high clinical suspicion of MOGAD, because multiple sclerosis is so much more common, and indiscriminately testing everybody would lead to high false positivity. There's a few next steps that we could do. Some studies have looked at comparing the clinical phenotype of patients who are positive in CSF versus serum, and some studies have found that the ones who are positive in CSF are more likely to have encephalitis. Now, we had small numbers, but when we looked at it, we didn't find a higher number more likely to have encephalitis. The only thing that we found different between the group that were positive in CSF or were positive just in serum was those positive in the CSF were slightly more likely to have relapsing disease. But again, this had a p-value of 0.06, just with small numbers. And then to see if these patients with CSF positivity, whether their disease phenotype is different. And I think what we would like to do, and what everybody should want to do, is look at prospective multicenter studies where we can look at a lot of patients and see if there is a difference.